Hi there, I'm Jamie Taylor. Welcome to Your Health Matters, brought to you by Kingman Regional Medical Center, your community-owned hospital. As you know, every week I have a different guest on the program. We talk about different programs and services provided here at KRMC. I've got an exciting guest today, so I hope you'll stay tuned. We'll be back right after these messages. Welcome back to Your Health Matters. My guest today is Lynn Damico. She is a physician's assistant and hospitalist here at KRMC, right? Did I get that right?
It's a mouthful. Yeah, that's it.
Well, thank you for being on the show today,
Thank you for
Lynn.
having me.
I'm excited to give a chance for our audience to get to know you better and learn a little bit more about what a physician's assistant and a hospitalist are, because those are two things I think that people aren't automatically, informed about. So, first of all, let's start with Lynn. How long have you been in Kingman?
It'll be 10 month.
All right. So you're one of our newer additions to the family.
Yeah.
And what brought you to Kingman?
Well, I'm originally from West Virginia.
Oh, okay.
And I was actually recruited from West Virginia to Mesa.
Okay. That's a little hotter down there.
A year ago, yeah. And I did a year in Mesa working for a hospitalist group in a 400-bed hospital down there. And I really enjoyed it, but it was just too hot.
I know. It's
so, and I'm from the hills of West Virginia, so I was like, we need to find a mountain somewhere in Arizona. So I started looking around, and Kingman was advertising for a PA. Mm-hmm. So I went and applied, and I couldn't believe it. I got the job.
Yay.
So
that worked out great.
It worked out great.
And you've got our Wallapies, so when you need that mountain fix, you can just drive up into the mountain and then come back down.
Yeah, it's beautiful up there. I was just up there last week.
Oh, good.
Yeah, it's gorgeous.
Yeah, it is.
It reminds me of West Virginia.
I bet it does.
The pine trees and.
Well, I'm from Minnesota originally, and so it's same kind of thing. Or it's very rare, but once in a while I kind of want a little bit of a snow fix, and you can just drive up there in the winter and then drive back down. My idea of a perfect winter.
Right.
Well, we're glad and blessed to have you here.
Well, thank you.
And that you chose Kingman. That's awesome. Yeah. So let's educate, as they say, our audience about, first of all, what's a physician's assistant?
All right. The physician assistant was actually created during the Vietnam War.
Oh.
Okay. There was a shortage of doctors, and they needed to transform their medical personnel into a more advanced practitioner, like a mid-level person.
Okay.
So that's how the PA came about.
Oh,
it's a physician-driven program.
Okay.
And it was originally in the military. So the first graduating class was in 1967 in North Carolina.
Well,
okay.
In your backyard, practically.
Right. Now, I originally went to school at the University of Maryland and graduated from there with a degree in nursing, a bachelor's degree. And I did ICU nursing for 2 years, and I wanted to go into the OR. I wanted to be a surgical person. And back then, nurse practitioners weren't going into the OR. They were family practice or pediatric practice. So I didn't go the nurse practitioner route. I took the physician assistant route, which was a 2-year additional education. I have 6 years total.
Wow.
So I did that, and actually I was very fortunate. I was very blessed. The hospital that I worked at as a nurse paid my tuition.
Oh, nice.
And they guaranteed me a job, and I actually did 7 years of surgery there before I left and went on to another position.
Okay.
So, and that was back in 1988.
Very good.
Okay. So, and we actually, our PA class, we started with 25 students, and we graduated 17. And it was the only school in the state of Maryland. So I was very lucky to get in. It was very stringent.
I was going to say, it sounds like it had to have been some tough courses.
Yeah, it's a very tough program. It's hard, like medical school in 2 years.
I was just going to say, it sounds like one of those crunched, where you learn a lot in a short period of time.
Right. It's a lot of rotations with physicians and pathophysiology, microbiology, chemistries. You have to go through all the specialty areas, and there's no time off in the summer. You work right through the summer, too.
Boy, were you married at the time?
I was married one time.
Well, I'm just thinking that's a lot
It is a lot.
to,
yeah.
for a family too, to
Yeah.
be, but hopefully if you've got a good support network.
Right.
Yeah,
Well,
that's
well, you know, back then I was young and
Right.
gung-ho and was going to save the
a lot
world.
more in
But
You can still save the world. I always tell people I may not be able to change the world, but I can change my little piece of it by making Kingman better.
there you go.
Yeah.
That's a great
Yep.
philosophy. I like that.
Yeah, and that's what you can do here too. You're going to touch a lot of people,
Yeah.
you know, here in Kingman. So that's awesome.
Yeah. And I
So-
work with a great group of doctors here.
With the
you
hospitalist
know.
group.
Yeah, the hospitals group. And, you know, everybody is very proactive.
Awesome.
Everybody's involved. And everybody is supportive.
Excellent.
You know, I got 4 great physicians that are supervising positions. Dr. Matheny, Dr. Wynn, Sharath, and Fort Kosh. You couldn't ask for a better group.
Awesome.
You
That's
know.
great.
And-
So let's then transition here a little bit and talk about hospitalists, because that is fairly new. It's a couple of years now that we've been doing it here at KRMC, and I think there's still a lot of people who don't understand what the
Right.
hospitalists are and do.
Right.
So,
Hospitalists are internal medicine doctors, board certified, okay, who only practice in the hospital. They
Okay.
don't have outside offices.
right.
Okay, so if you should come into the emergency room and you have a primary doctor on the outside, but they do not have privileges here,
Okay.
then you would be admitted to our service.
Okay.
And once you're discharged, you go back to your primary care physician that you had before. We don't follow the patients on the outside.
Right. But you like do the discharge as far as turning them over, giving them
Right.
their medications, their instructions, what they need to do. You need
Right.
to see your primary care in 10 days or
Right.
that type of thing.
Right. We give you the prescriptions to give you enough medicines, usually for a month, so you get time to get in with your your primary care physician. But while you're here, you know, we'll take care of you. We'll order the tests that need to be taken care of. We'll give you the medicines that need to be done, any therapies. We refer people for rehab afterwards.
Okay.
Um,
And you work closely, right, with their physicians? I mean, as far as
Right.
keeping the physician in
in the loop.
the loop. Yes, thank you. That's the word.
Right.
No,
Yeah.
and it's not just physicians who don't have privileges here, right? Because there are a lot of the KRMC employed physicians who we've found it kind of frees them
Right.
to turn over their patients' care to the hospitalists while they're here in the hospital,
Right.
and then frees them to do more of in the office,
Yeah.
and then
Yeah,
go
so they can stay in the office and take care
Right.
of more people, send the sicker ones to the hospital.
Yes.
That
Otherwise,
saves
they're
them time.
Yeah, they're dividing themselves. I'm sure they all wish
Right.
they had clones at some point, because they have to be, see patients in the office, and then they have to see patients in the hospital, and
Right.
that makes it really
It's-
difficult.
It's very difficult.
So you're enjoying being a hospitalist?
I
then?
do. I've been doing this for over 25 years, and I was a hospitalist even before they called us hospitalists. we were called house staff.
Oh, interesting. Okay.
I think the term hospitalist came into vogue the last few years, and
Probably
so
in like last 5 to 10,
yeah.
something like that. But that's
But
pretty cool.
I've never worked in an office or an urgent
Okay.
care or anything.
Just
I've
in the
always
hospital.
been hospital based.
Awesome.
So it's a whole world when you're in a hospital. You know, you deal
Right.
with so many people, so many departments, and you have to take a picture of the whole thing, the whole person.
Right.
You know.
Yeah,
so-
because
and
you're involved in that whole level of
we're very
care.
fortunate here at KRMC. We have a lot of specialties,
Mm-hmm.
and the ones that we don't have, we're in contact with Mayo.
Yes,
so
that's another.
that's a
great-
whole other realm that we're going down with teleneurology and
Yes.
telemedicine. So, you know, if we don't have a specialist here, we at least can contact one in Mayo down in Arizona,
Right, Phoenix. yeah,
Phoenix. Yeah.
to be able to connect that way. And I think you can even do video conferencing, right?
Well,
So you-
we can do the video with the neurology patients.
Okay.
It's like, it looks like a robot.
Really?
Yeah.
That's kind of cool.
You just wheel it in,
Yeah.
and the neurologist's face appears on the screen.
Oh, wow.
Yeah, and they actually examine the patient, they talk to the patient, and
Kind of like Skyping,
Yeah.
sort of.
Yeah, it is.
I haven't actually Skyped myself, but from what I've heard,
Yeah,
it's that
yeah.
kind of thing.
Yeah.
That's awesome.
Yeah, and I'm
And
sure
then-
that's going to broaden and expand too to all specialties, not just neurology.
Sure.
So.
Well, it makes sense because there is so much of that that can be done long distance, if you would. I mean, because we have a doctor here that's kind of overseeing it, but doesn't necessarily have that particular background.
Right.
And so much better for the patient if we're able to keep them here
Right.
versus shipping them to Vegas or to Phoenix.
Right.
I mean, the stress for both the patient and the family.
Right.
When you've got a family member that's up in Vegas and you're here in Kingman and trying to get back and forth, obviously,
Right.
that certainly makes, and we've talked about before, we've had other guests on the show talking about how stress affects a patient's recovery.
Right.
And when you're stressing over that kind of stuff, that doesn't make it any easier.
Right.
So
Right.
that's pretty cool.
Yeah.
Now, you mentioned that you did, you were in the operating room for how long, 10 years?
7 years.
7 years, okay. And
And then after that, I did a 3-year rotation or specialty in in-hospital neurology.
oh,
So that was very interesting.
yes,
And then I kind of went from that to medicine, general medicine.
okay.
And pretty much what I've been doing now.
It's the general side
General
of it.
medicine.
But it's
yeah.
got to help you having that neurology background
Yeah.
too, with what we're talking about here with the video conferencing for Mayo.
Right.
So,
Right.
I bet you're the one they call.
You got to give them a plug, right?
Yeah, right. Well, it certainly it helps, like we talked about, having that relationship with Mayo
Right.
has opened up whole new windows for us as far as patient care. That we're
Right.
able to keep patients here, but also it's given us kind of a pipeline for new doctors too, has been nice.
Yeah.
Some of our, most of our radiologists now are from Mayo, and we've had a few other docs that have gone through the Mayo system.
Right.
And that's pretty cool.
Yeah, and
So-
it seems like every doctor that I've met from Mayo, I mean, they're so nice and so proactive.
Yes. Very
you know.
personable. and-
Yeah, they're very approachable.
Right.
You know, they're not talking way above your head. you know.
One-to-one kind of thing.
Yeah.
Yes.
Yeah.
That's been my experience too, so it's nice to know that it's not just me.
Yeah, and it's not just, physicians or practitioners, it's the patients too. I mean, they bring it down to the level that people can understand,
That's huge.
and they don't try and talk above their heads and
Right.
with fancy dancy medical words.
Yeah.
You know.
That makes I just think that's makes again the patient's comfort level, if
Right.
you would, so they can understand.
Right.
Talking English to me again.
Yep.
And it does help if you're part of understanding what it is they're trying to tell you, so then you know what's going on and what's expected of you,
Right.
if you would. Now, you were talking a little bit about all the different departments that you touch, or that are touched by a patient and that are involved in that patient's care. I think we're going to take a quick break, and when we come back, let's talk about how you interact and the relationships you have with all those different departments.
Okay.
Okay, so we'll be back right after these messages. Stay tuned. Welcome back to Your Health Matters. My guest today is Lynn Damico, physician's assistant and hospitalist here at KRMC. I got that even better
Very
that time
good.
around. So, Lynn, before the break, we were talking about the whole person care, the whole body care, and all of the departments that you work with when it comes to that inpatient care.
Right.
So we're talking lab,
Right.
blood work, right? X-rays,
Right.
pharmacy for medications,
Don't forget dietary.
dietary, nutrition, because that is
Housekeeping.
yes,
You
yeah,
know, case management. People don't realize that the minute that you are admitted, people are working on your discharge.
and that's kind of that's more an insurance side as
Right.
well, right? Because
Yep.
insurance nowadays, they're pretty tough as far as
Yeah. It used to be that the doctors would dictate care.
right.
Say you're in with pneumonia, we'll just keep you,
Till your lungs
6
are
or 7,
clear.
maybe
Yeah.
9 days and see, until you're okay.
Yeah.
And now the insurance companies are dictating it's a pneumonia, you got 3 days.
to get them better, and
Yeah.
then they're out of here.
Yeah.
Kind of like when you have a baby. I remember with my first one a couple of years ago now. And I think I was in the hospital for a week, and it was really nice, and I got back rubs and, all this good stuff. It was awesome, very pampered. And then when I had my second child, it was 3 days, and I went, what? I got to go home already? I'm not ready?
Yeah.
And now it's, 24 hours if you're
Yep,
lucky.
24 hours.
And you're out of there.
When I first started in medicine, when I worked in the ICU, and a patient would come in with a heart attack, they were kept on bed rest for 7 days.
Right.
And now, medicine has progressed so fast.
Yes.
And so many things that we can do with interventional procedures, both interventional radiology, interventional cardiology. They put that stent in, and
they're up and
you're
moving.
out. Yep. You're out. I worked in a cath lab for a couple years, and it was in and out. It was an in and out procedure.
Right, they're like outpatients.
Yep. You
now.
checked in the morning, you were discharged in the evening.
Yeah.
If that's
Right.
everything went okay. Now,
Right.
if there were problems or concerns or complications,
Obviously,
you
then
obviously got admitted
Right.
and stayed. But now it's an outpatient.
Yeah, that's just amazing. There's good things about that, obviously, because it does show how, as you said, how much we've progressed in
Right.
our healthcare. But at the same time, like I said, you better just get better quick and
Yeah. Yeah.
be
Right.
prepared, hit the ground running.
Right.
So like you said, from the minute a patient basically is coming in, case management gets involved and starts, they're the ones, or kind of, I think they have that insurance person that figures out how much time they
Right.
have, right?
Right.
Now, so if, for instance, you've got pneumonia, use that example, and insurance says 3 days, but you have complications, and can the doctor then go back to the insurance company and go, no, they have to stay longer?
Yeah.
because-"
It's all with patient safety.
Okay, good.
We're not going to discharge somebody that's not ready to be discharged.
Right.
Now, it's not saying they have to be in a hospital, though. There are
True.
these intermediate places that people can go, like subacutes or
Okay.
acute rehabs.
Assisted living kind of
Yeah,
places.
that type of thing where
Okay.
they don't need to be in the hospital, but they're taking longer than expected to progress, and they need therapy or they need oxygen, they need rehab before they're strong enough and independent enough to go back to living at home.
Well, and a lot
So-
of it depends on what their home environment is. If they live alone,
Right.
obviously,
That's
you're
a
not
that's a
gonna-
big risk.
Yeah.
When people that come in that live alone, and we have to take into consideration, what are they going back to, and we don't want to discharge someone unsafe
Right.
in an
right.
unsafe environment.
Right, yeah, because if they could fall or not.
And that's why we depend so much on case management
Okay.
and the nurses and the social work to dig out this information, because a lot of people aren't very forthcoming. Then they can be somewhat embarrassed and they
Right.
don't want to, say these things. So we depend on other departments to work as
Ask
a team.
The probing questions.
Yeah,
What-
yeah, exactly.
You made me laugh because I thought I had a physician once, one of my personal doctors, one time was asking me, interviewing me for my physical, and I forget what question she asked, but anyway, and she goes, my father was a doctor, and he told me that patients lie. And I went, what? And she goes, not on purpose, but they just seem to forget a lot of us. She said, so it's my job to make sure I keep asking you until I get all of the answers.
Right, right.
So it's kind of what you're talking about is they
Exactly.
either aren't always forthcoming or might not think about it or forget about it,
Right.
whatever. So
Yeah, and it's funny because we were talking about all the different services in the hospital, and I have people telling me things from physical therapy. Hey, did you know so-and-so has 14 steps to go up? I was like, no, I didn't know that. I didn't even think of that.
So again, it's that communication
Yeah.
between departments
Right.
that really help you when you're providing
Right.
that care for the patient and helping with their discharge.
Right.
That's great.
Yeah.
And now, I know we have therapy. We've had them on the show and stuff before. So it's inpatient therapy that you work with the closest probably?
Yes. Well, inpatient, when the patients are admitted to the hospital, we have inpatient physical therapy, occupational therapy, we have speech language pathology. They also work with people with that have speech problems or they have trouble swallowing, or if they've had a stroke, sometimes their face and their muscles on that side are affected. So I work with those three departments.
Pretty closely.
Yeah.
Okay, very good. And nutrition. That's pretty important too. Obviously,
Yeah.
what we put into our bodies helps us.
Yeah, I mean, people don't think that dietary and nutrition is important, but if you ask patients, if they had a bad experience at the hospital, they may tell you, oh, it was terrible, the food was just awful, But here it's just the opposite. Everybody's like, oh, the food's great. Okay, but how's your pneumonia?
Yeah.
How are you breathing? The food was wonderful.
Robin Rush will be very happy to hear you say that.
It does. People are always commenting on the food.
Yeah.
I was like, yeah, I mean, I go in to examine patients, I'm looking at their tray, it looks pretty good,
Yep, for hospital food, it's pretty amazing. I mean, we have people here in Kingman that actually come here to eat.
Yeah.
I mean, they don't get admitted, but they go to the
Right.
cafeteria
Right.
to have lunch and dinner. We have a lot of clubs that meet here and have their breakfast meetings. So.
Right. And if the patients aren't able to take food or if they're having problems with malnourishment, then we get nutritional services involved,
Get our
and they help us
dietitians.
with how to get nutrition into the patient, whether it's through a tube or through an IV,
Okay.
so we can get nutrition going.
Right. Because your
from
body
the very early. You don't want to wait until the
'cause
patient's
you need that.
severely malnourished
Right.
before
you
you
need
start.
that energy to
Right.
start healing.
Right.
That's their energy source, right?
Right, right. And if your stomach works,
Yeah.
we're going to put food in it to let it
Very
work.
good.
But if you can't, if there's surgery or something
Mm-hmm.
like that, that their stomach and intestines aren't working, there's other things you can do. There's IVs that you can put in
Okay.
to give total nutrition
Uh-huh.
that way, peripheral nutrition,
Okay.
until their gut starts working,
Yeah.
then you can start feeding.
Okay. Yeah, that's always a good thing. I'd much rather chew it than
Yeah.
keep those muscles working.
Right. Right.
Well, that's pretty cool. And the case management, I've just recently had Leanne Strasser on the show. We're talking about case management and the role they play in ensuring, like we were talking about, making sure insurance is going to help cover the costs for the patient, because obviously you don't want the patient to be stressing over their bill either. And then, but helping them finding where their next steps are once they leave, and making sure, because we don't want them to come back. They don't,
Right, and the other problem is when people come in, they don't have insurance.
And they
They
work with
help
that.
them acquire access, or we kind of facilitate things in the area. Like I know one nurse that called Goodwill and got some clothes for a patient.
awesome.
And Goodwill
Yeah.
was more than happy to donate. I think it was shoes. They didn't have any shoes.
Oh, wow.
So we got
Yeah.
the neighborhood Goodwill store to
Yeah.
donate some clothes and some shoes.
Kingman has a huge heart. I think as you're here longer, you
Right,
see it even
right.
more,
Yeah.
that there's always these different areas and programs that are out there to help. I see it all the time.
And pharmacies too.
Yes.
Like I think it's Uptown Pharmacy that will actually help us give patient medication for a limited time. But if you need the antibiotic for a week and you
gotta
don't have
have
any
it.
money,
Yeah.
I mean, we're so lucky to have them.
Yeah. Well, it's part of that, I think. It's just the culture of our community, because it's been a small rural community for so long, and everybody, and even though we've grown, we're still small enough that most people can, know each other. They recognize you, run into each other at Walmart or the movie theater or whatever.
Yeah.
And so it is the buy-in that we have of support for each
That's
other.
funny because, everybody say, oh, this is a small rural. I was like, you don't know what rural is.
Okay, so
I go,
tell me.
Let me tell you what rural is. Rural is a 20-bed, licensed for 20 beds hospital with an average census of about 12 patients.
Oh my goodness. That was
In
that.
rural West Virginia.
That was West Virginia. That's small, you're right.
Your emergency room is 2 beds.
Oh my goodness.
There's no ICU. It's you.
So you do it all.
You do it all.
But
Yeah.
now, did you have to ship out a lot then?
Well, yeah, it's kind of like the Mayo is with our connection with Mayo. The small little hospitals in rural West Virginia are connected to a larger
Okay.
facility.
Right.
So,
So then when they have someone come in with a
Yeah.
very acute situation, they can transfer them.
right,
to
and that was
bigger-
my job. My job was to decide, is this patient stable enough to stay here, or do I need to transfer that patient to the mother hospital.
Right. The mother hospital, the mothership.
The mothership.
Very cool. Well, Lynn, thank you for being
Oh,
on
you're
the program
welcome.
today. Get to know you a little bit better, and maybe we'll have you back on the show again sometime
Yeah.
in the future. We can talk about other things.
Yeah.
I'm glad you joined us today, and I hope you learned something new. And I hope you'll join us again next week when I'll have another great guest on the program.